right? So what is this disease? It's a potentially devastating sequelae of serious underlying ocular or systemic disease, which is mostly ischemic in nature and causes neovascularization of the iris, which is called as NVI, or neovascularization of the angle, which is called as NVA, that ultimately leads to neovascular glaucoma. So the synonyms which may be used by few of the people are hemorrhagic glaucoma, thrombotic glaucoma, rubeotic glaucoma. There are a lot of predisposing factors which are there, like you can see the list, the huge list of the diseases, but we'll concentrate on the top 3 causes of NVG, namely the diabetes mellitus, which causes around 30 to 70% of NVG cases, retinal vein occlusions, which accounts for 20 to 36% of NVGs, and carotid occlusive diseases, which accounts for 2 to 13% of NVG. So let's come to the first most common cause of NVG, which is diabetic retinopathy. So it accounts for approximately 1/3 of the cases, and there is a high prevalence with proliferative diabetic retinopathy. Next comes the CRVO. So NVG is more commonly seen in ischemic CRVO vis-a-vis non-ischemic. And the study demonstrated, CVOS study demonstrated a conversion rate from non-ischemic to ischemic in around almost 1/3 of the cases. And that is why it is very important to follow up the patients closely over time to monitor for early signs of neovascularization. The third one is carotid artery obstructive disease. So a low intraocular pressure in the setting of an NVI and NVA should raise a suspicion of carotid artery obstructive disease. So especially if there is low IOP in the absence of a retinal detachment, if there is a gross asymmetric diabetic retinopathy, and if there's a persistent NVI even after PRP. If there is an unidentified etiology for NVG even after a full ocular examination. So all these conditions should raise a strong suspicion of carotid artery obstructive disease. Prompt diagnosis and treatment can save not only the eye, but also the patient's life. And that is why it's a very, very important entity to be kept in mind. What's the pathophysiology of the disease? So any kind of ischemia, retinal ischemia, causes reduced perfusion or non-perfusion of retina. Hypoxia is created, and there is a release of vascular endothelial growth factor, which causes pericyte activation, endothelium proliferation, and in return causes angiogenesis. Important points to be kept in mind is the lens vitreous act as mechanical barriers and also release vasoinhibitory factors. So any breach of the posterior capsule, which may occur in 2 conditions, either you can have a complicated cataract extraction or a capsulotomy, laser capsulotomy. This allows angiogenic factors to gain access to the anterior segment, accelerating the neovascularization of the anterior segment. So what do we get in the examination? So, detailed history in a patient with elevated intraocular pressure and comprehensive ocular examination for neovascularization, especially in patients where the eye is predisposed to NVG, needs to be done. Particular attention is to be given to the pupillary margin, and it is to be examined under high magnification. Angle structures need to be seen, and there has to be a detailed dilated fundus examination. A non-dilated gonioscopy is an easy, cost-effective, and quick office procedure for early detection of NVA. So let's come to the stages of neovascular glaucoma. This is the first one where the neovascularization has occurred, and it is formed from the minor and major arterial circle. There is a fibrovascular membrane, which is nothing but actually a histological membrane, not visible clinically. If it progresses in the second stage, the membrane crosses over the trabecular meshwork, causing its obstruction, and thus the IOP rise follows. This is the open angle stage. And when this membrane contracts, it forms a zippering of the angle, pars formation, and this is the angle closure stage. So let's look at each stage carefully. So stage 1, as I told, is the rubeotic stage, where there is neovascularization, but the patient is asymptomatic because the intraocular pressure is normal. So NVI, the neovascularization of the iris, may be seen as fine. arborizing or branching, superficial and leaking vessels, especially near the pupillary border. So the left side photograph shows pupillary border NVI, and the right side photograph shows NVA, which is neovascularization of the angle. So as I told, when this progresses, if the treatment has not been given in the first stage, the membrane, it blocks the trabecular meshwork. So there will be increased NVI and NVA. Now the IOP starts rising and there will be anterior chamber inflammation. There may or may not be hyphema. Still, the angles are open. There is no peripheral anterior synechia. Histologically, there may be a fibrovascular membrane which may be elicited. So this covers the angles and obstructs the aqueous outflow initially. So what happens at the third stage? As the disease progresses, the proliferating myofibroblasts of fibrovascular membrane contracts, and this leads to ectropia on UVA, peripheral anterior synechia, and total angle closure. And this is how it looks. The top photograph is of ectropia on UVA, and the lower one is a total zippered angle. So most of these patients are detected in this stage. Why? Because now the patient will be symptomatic, the intraocular pressure will be very high. Unfortunately, this is not reversible by PRP. The resultant glaucoma is often refractory to the management and mostly requires surgical treatment. So again, the clinical features, the patient will come with severe pain, headache, vomiting, redness, watering. There will be decreased vision and photophobia. And when you examine the patient, there will be a reduced vision and ciliary injection, corneal edema, hyphema may be there, NVI, NVA may be there, and there will be fixed dilated pupil with a raised intraocular pressure. What are the investigations which need to be done in neovascular glaucoma patients? So in the ocular investigations, the first and foremost is the fundus fluorescein angiography. This is basically to assess the retinal ischemia. ERG may be done. Again, it tells us about the retinal ischemia, not routinely done. Iris angiography, again, is not routinely done, but can be done in doubtful NVIs. Ultrasonography is done if the retina is not visible, just to assess the posterior segment. Systemic evaluation is important for diabetes. If the patient is not a known diabetic, then investigations need to be done. There may be a carotid Doppler, which may need to be done in patients where we suspect OIS or ocular ischemic syndrome. Lipid profile and renal profile will need to be done. So coming to the treatment, what are the main two objectives? The first one is to identify the etiology, because that is the reason why the patient has developed neovascular glaucoma, and it's timely and adequate treatment to prevent the development and progression of the disease. And the second objective is to control the intraocular pressure. So to prevent, this is done to prevent the optic nerve damage and treat the, again, it goes in concurrence with the first point. So this is a preventive measure, pan-retinal photocoagulation. It's the procedure for choice for ischemic retinal disease, and it has been shown to reduce and eliminate anterior segment neovascularization. It usually reduces or stabilizes the intraocular pressure in open angle and may improve the outcome of filtration surgery preoperatively. PRP should be performed at the earliest sign of neovascularization. So the anterior segment, so the anterior segment consultants should send the patient for a vitreoretinal consultation. So how does PRP work? It makes the ischemic retina anoxic, thereby decreasing the angiogenic factor and decreasing new vessels, and thus reduces the anterior segment neovascularization. So 1200 to 1600 burns are usually given, approximately 500 micron spot size, one spot apart, ideally completed in 1 to 3 sessions over a period of 5 to 7 days. So in diabetes, if there is established PDR, PRP is combined with intravitreal anti-VEGF to prevent NVG. The patient needs to be under a close follow-up. In cases of CRVO, PRP is indicated only after 2 hours of neovascularization as per the study. And in ocular ischemic syndrome, it is indicated for cases with retinal ischemia on FFA. A very important point is a neurological and cardiology assessment is required. In cases where PRP cannot be performed because of media opacity, pan-retinal cryotherapy or transcleral diode laser retinopexy can be used for retinal ablation. Another option is to use endolaser or indirect PRP during pars plana vitrectomy and, if needed, lensectomy. Gonio photocoagulation is only an adjunct to PRP. It does not eliminate the vascular angiogenesis. So it is aimed at directly treating the NVA before the development of NVG and has no role once the glaucoma has been established. The medical management includes mostly the aqueous suppressants. Prostaglandins will not be effective if PAS has developed because it limits uveoscleral outflow and also increases inflammation. The same is the case with myotics, which is actually contraindicated because it can increase the discomfort and inflammation. Topical steroids and cycloplegics are added. Osmotic agents may be given if the intraocular pressure is very high. And if corneal edema is preventing PRP, then topical glycerin may be applied. Anti-angiogenic drugs like bevacizumab, intravitreal or intracranial, reduces angiogenesis and reduces inflammation, especially preoperatively. So in advanced stage where synovial closure has ensured, surgical intervention for intraocular pressure lowering is often required. And usually these are the three surgical parameters which are used. First is trabeculectomy, second is tube shunts, and the third is cycloablation. So the success rate of trabeculectomy with mitomycin C at 1 year was studied by Takihara et al. And it has been reported to be 62.6%, which reduced to 51.7% at 5 years. So you would notice that the success rate is a little lower. It is usually complicated by intraoperative bleeding and progression of the membrane postoperatively. So with the use of, as I told, preoperative bevacizumab, success rate may improve up to 95%.
Sorry, ma'am, can we wind it up in next 30 seconds, please?
Yes. So antifibrotic.
Ma'am, you are not audible, ma'am.
Richa, you're not audible.
Ma'am, you're not audible.
Hello?
Hear you, Richa. We can't hear you.
AV, can we please have some help on this, please?
मैम मैं उसमें वो सुनी मैं कैसे कर सकता हूँ मैसेज भी कर दिया उनको रिप्लाई नहीं कर रहे हैं